class. Assalamu alaikum. Hello everyone. My name is Fawaz Al-Nujaydi. I'm your colleague from 4th year. I hope everyone's having a great day. I hope everyone's staying safe in this pandemic. Today we will be talking about a very interesting topic, which is the common pediatric infections. And usually this topic, we encounter a lot of patients in the pediatric hospital and pediatric clinics with these presentations. So without further ado, let's get started. So first, I would like to initiate my talk with a quote. So the chapter you're learning today is going to save someone's life in the future. So please pay attention. Okay, so we're going to talk about several infectious entities today, inshallah. And I'm going to be pointing out several tips and tricks on how to differentiate each entity from one another. And how could you actually solve the MCQs in the exam, inshallah. So first, we're going to talk about the roseola, which is the Xanthum Phase or sixth disease. So why is it called sixth disease? Because it's usually caused by human herpes type 6 and less commonly by human herpes type 7. So how do patients present? They present with upper respiratory symptoms such as runny nose, sore throat, and conjunctivitis, a combination which we call coryza. Usually, patients come with a very high-grade fever, more than 40 Celsius, that can actually lead to febrile seizures sometimes. And an important point to note here is that after the fever breaks, so after the fever is gone, the patient will present with a rash. Because we have another entity, both high-grade fever and the rash occur together, that we're going to be talking about. The skin rash is non-purulent, so it's not itchy, and blanchable. Blanchable means when you press the skin, the rash will disappear. So which means it's originating from the skin itself and not from the blood vessel. The patient usually looks well, which is a bit odd to have someone with a very high grade fever presenting with or looking well and not toxic. So this is also another hint for you. Okay, the second entity we will be talking about is the herpes viruses family. As you can see, we have multiple families that we will be covering today, inshallah. First one is human herpes type 1, human herpes type 2, type 3, which is the varicella zoster, type 4 is the Epstein-Barr virus, type 5 is the cytomegalovirus, 6 and 7 is the Xanthum Phase we just talked about, and 8 is the Kaposi sarcoma, or 8 causes Kaposi sarcoma in immunocompromised patients. Okay. We're going to talk about the most important ones, which are the herpes simplex type 1 and type 2. So in type 1, they usually present as oral and skin ulcers, which is known as gingival stomatitis. In 2, they present with genital ulcers, which is known as herpes genitalius. Okay, they usually present in clusters. What do we mean by clusters? It means that this viral infection is highly contagious between children who are, for example, in a kindergarten. Because they're usually in contact with one another, roaming around the kindergarten, usually they can spread the infection very quickly and they come to the hospital in clusters, like there are many of them. Keep in mind that one can cause genital ulcers and type 2 can cause gingival stomatitis. So either one of the virus can cause either one of the presentation. Okay, so what are the most important presentation when it comes to herpes simplex type 1 and type 2? Usually we have many of them, but I'm going to talk about skin manifestation and oral mainly. So in the skin manifestation, they may present as something we call eczema herpeticum. So in eczema herpeticum, the basic idea is that the patient is having atopic dermatitis, which is eczema. And then it's complicated by herpes virus. So usually they present with a rash. They call it an ugly rash, as you can see in the lower picture. This is highly, it increases the risk of having secondary bacterial infections of, for example, Streptococcus pyogenes and Staphylococcus aureus. And herpetic with low, as you can see in the picture, it is a combination, it is a collection of abscess in a finger. So you'll have a painful pustule in the finger. And then the oral manifestation, which is the gingival stomatitis. Again, they present with painful ulcers in the mouth, where exactly? Most commonly in the inner cheek, soft palate, and tongue. An extremely important point here is because they have painful ulcers, when they present to the hospital, the first thing that you need to do is rehydrate the patients. Because when you have someone presenting with a painful ulcer, obviously they haven't eaten or drank anything in the past God knows how many days. So you have to rehydrate the patient well. And because it's a viral entity, so obviously you need to also give supportive treatment. Okay, the third entity we will be talking about is the Varicella zoster, which is the human herpes type 3. Okay, human herpes type 3 is also known as chickenpox. Chickenpox, in fact, is extremely contagious, and that's why we usually put them in airborne isolation. We have two phases. We have the prodromal and we have the xanthum phase. Prodromal, usually, again, they're not specific symptoms. They come with fever, anorexia, malaise, and headache. What we care about really is the xanthum phase. So in the xanthum phase, they usually present with a rash that starts from the trunk and then goes to the face, scalp, and extremities. But how is the characteristic of this rash? What is the characteristic of this rash? They usually present with erythematous macules. What macules mean, it means a non-palpable skin lesion less than 1 centimeter in size. And then they turn into papules, which are palpable but still less than 1 centimeter in size. And then they become teardrop vesicles, which means it's like literally a sac filled of fluid. This sac, which is the vesicle, is gonna rupture, and then you will have crusted papules. Okay, so what are the most important things that we need to know about chickenpox? First of all, is that it is extremely pruritic rash, meaning it is extremely itchy to a point that if the child itches the rash aggressively, they're gonna have a permanent scar and pigmentation. So be aware of a child whose fever settles and then reoccurs. Why? Because it means that the child is having a secondary bacterial infection, whether it was by Staphylococcus aureus or Streptococcus. They're having a secondary bacterial infection. A third point important also is never, ever, ever combine an immunocompromised child with chickenpox patient, because literally you will end up with a disaster, because they will have disseminated intravascular coagulation, hemorrhagic lesions, and pneumonitis, which is obviously lethal. Okay, so usually, like, when does the chickenpox resolve? How many days does it take for the chickenpox to resolve? It takes 3 to 5 days. And those 3 to 5 days, lesions are appearing and disappearing. So they're not all appearing at the same time, and they're not all disappearing at the same time. Okay? But an important point is, if a patient comes with a lesion or still new appearing lesions after 10 days, this indicates that the patient is having a problem in their immunity, whether he's immunocompromised or has immune defects. So an important question would be from the mother is, when can my child go back to school? Your answer to that mother would be when all the lesions are crusted. So after 5 days, when all the lesions are crusted, the patient can actually go back to school and is considered no longer contagious. Okay, a fun fact is, back in 1970s maybe, they used to do a chickenpox party. This party is when, for example, a child got chickenpox, they would get other children to get in contact with this patient so they can all get chickenpox in a young age and don't have to suffer from it later on as adults. But this is extremely dangerous because, as we mentioned, immunocompromised patients can actually die from this event. So be careful. Okay. Moving on to our fourth entity, which is the shingles. Shingles is also known as Herpes Zoster. An important thing about shingles, the important things that you need to know, is that it's a reactivation of Varicella Zoster, the entity we just talked about. But it is not common in children. It is usually in elderly and immunocompromised patients. We will mention why. And usually it is dermatomal in pattern. It comes at certain dermatomes, most commonly thoracic and lumbar dermatomes. To understand the pathophysiology, what happens exactly in herpes and shingles, herpes zoster, what happens is that when you get infected as a child with Varicella zoster, it will be residing in your dorsal root ganglions. And then as you grow up and the patient becomes more immunocompromised, whether by comorbid conditions or whether because of the advancing age, what happens is that these viruses will migrate through the peripheral sensory nerve and go to your skin and manifest as dermatomal patterns like the picture you see on the right. Okay, our fifth entity is the Epstein-Barr virus, which is also known as infectious mononucleosis, or the glandular fever, or human herpes type 4. Okay, usually patients with Epstein-Barr virus present with, again, upper respiratory symptoms such as fever, congested throat, conjunctivitis, photophobia. But an important thing that will help you in recognizing this entity is that they come with lymphadenopathy in 90% of patients, and they come with hepatosplenomegaly in 50% of them. And also, usually when you do, for example, a complete blood count, you will find they have a lymphocytosis, more than 4,500, and more than 10% of them are atypical forms. So if you had an MCQ with lymphadenopathy, hepatosplenomegaly, more than 10% atypical forms, it is directly mononucleosis. But the thing is that mononucleosis is a bit difficult to diagnose clinically. So what we do is we need to further investigate because it can manifest a bit like other entities, for example, cytomegalovirus. So we need to be careful. An important thing about mononucleosis as well is that the rash that they have, they may present with a rash sometimes. And the rash that they present with is because of the virus in only 5% of patients. So in the last, and the meaning they only present, the rash they present with is caused by the virus in only 5%. For the rest of the 95% is because of the medication they're given, the patients are given. Okay. Okay, moving to our next entity, which is the congenital cytomegalovirus infection, which is human herpes virus type 5, or the torch infection. Torch infection are a group of infections that pass from the mother to the fetus through the placenta. A quick example would be Toxoplasmosis gondii, Treponema pallidum, Listeria monocytogenes, Varicella zoster, and a lot of them. Okay, but how can we recognize cytomegalovirus? First of all, we need to understand that usually patients infected with cytomegalovirus die in the first 6 months. But if they survived, they will be presenting with the following symptoms, which occurs in the first or second trimester. For example, they may come with jaundice, hepatosplenomegaly, periventricular calcifications, blueberry muffin, sensorineural deafness. But the most important are the ones in bold. You need to memorize them. I remember a question coming about the manifestation of cytomegalovirus. And again, because it looks similar to Epstein-Barr virus, we need to further investigate to try to differentiate between them. And because also blueberry muffin comes in rubella, which is also a fetal infection, so that's why we need to differentiate between them. Okay, our seventh entity is the measles, also known as first disease or rubiola. Rubiola. So the one we talked about, the first entity was rubella, was Roseella infantum. This is rubiola, and then we're going to talk about another entity which has also the same name. So please try at least to differentiate between them because they can be a bit confusing. Okay, so measles, I call measles the disease of 3. Why? Because they come with 3 C's that start 3 days before the rash. Okay, so what are these 3 C's and 1 K? 3 C's are low-grade fever, 3 C's are the cough, coryza, and conjunctivitis. The K is complex spots, which is found on the buccal mucosa, as you can see in the picture down here. These are considered as pathognomonic for measles, although they're a bit clinical hard to recognize, but if so, they're pathognomonic. Okay, what about the Xanthum phase? They usually present with a high-grade fever, more than 40 Celsius, and they come with a rash that starts behind the ear and disseminates to the rest of the body towards the feet, and also disappears in a craniocaudal pattern, which means it disappears first from the head and then the rest of the body, leaving a desquamation that will last only 7 to 10 days. Okay, So we talked about previously an entity that come with high-grade fever, which is the Roseella infantum, but we mentioned that the rash comes after the fever breaks. In this case, in measles, no, you're going to have a high-grade fever, but the rash will occur at the same time. Usually the rash are going to spare the palms and soles, but not like most commonly they spare the palms and soles, but it's not like an actual rule. No, it can affect the feet, but not always. And you need to understand that nowadays we don't really see measles because of the vaccine we usually take at 9 months of age. Regarding the measles, they did not really ask us in the exam about the incubation period, and they did not really focus on which day the rash appears or which day whatever happens, because they want you to understand the basic idea and like to just differentiate between the entities. Okay, what are our must-knows? First of all, the rash is blanching. Like we mentioned before, it disappears on pressure. It's a macropapular rash and it starts with the fever. Usually in immunocompromised patients, it may lead to pneumonia, giant cell pneumonia, measles, inclusion body encephalitis, which can be lethal. So again, we need to be careful and take care of our immunocompromised patients. Okay, the eighth entity we're going to be talking about is the rubella. So we talked about Xanthum subitum, which is the Roseella infantum, and then we talked about Robiola, which is the measles, and now the rubella. It's also known as German measles or third disease. Usually, rubella and measles are extremely similar. So I'm just going to point out the differences and similarities for you guys to help you guys out. Okay, so in the similarities between measles and rubella, they all present with a macropapular rash that starts from the head, from behind the ear, and extends to the extremities, sparing the palms and toes, as we mentioned. And the rash usually resolves in the same pattern, which is craniocodal. The differences between them is that usually in rubella, they have three differences. They come with tender cranial lymphadenopathy before the rash in 24 hours. They come with polyarthritis and polyarthralgia after the rash in 1 week. And they come with something called the Faucher-Mears sign, which is a mucosal rash, as you can see on the soft palate. So in the measles, we have Koplik spots. In the rubella, we have this rash. So be careful. Okay. Our ninth entity is the Parvovirus B19, also known as Edema Infectosum or fifth disease. So this is very easy to recognize, and it's a very clear entity. Usually they come with cold-like symptoms such as low-grade fever, headache, nausea, and vomiting. And then, cold-like symptoms, yes. And then they present with a slapped cheek rash. As you can see in the picture here, I remember them also they bought this photo in the exam. So, okay, so they come with a slap cheek rash, and it's usually sparing the perioral area. So this is spared usually. Okay, then this slap cheek rash will spread as a macropapular rash from the trunk to the extremities, giving a sock and glove configuration. So two very important rash characteristics in Parvovirus B19, slap cheek and sock and glove configuration. Once you see them, most likely the diagnosis is Parvovirus. Usually they got worse upon exposure to sun, with stress, with exercise, so we need to be careful. Usually they come with symptoms such as arthralgia with symmetrical non-destructive polyarthritis. So this is our second entity that comes with polyarthritis. The first was rubella. They came with polyarthritis 1 week after the rash. And here the Parvovirus B19 also comes with polyarthritis. They come with aplastic crisis, which is usually in sicklers. Okay, we're going to talk about our 10th entity, which is the Coxsackie A or enterovirus. So this is known as hand-foot-mouth syndrome disease. Why? Because hence the name. First, to start off, they usually come as clusters, like herpes simplex virus, type 1 and type 2. They come as in clusters because it's quickly spread between kindergarten children, and they present to the hospital as clusters. Usually we have two types of rashes. We have a macropapular rash and we have a vesicular rash in this entity. So in macropapillary or partially vesicular, it will come in the hands, feet, and buttocks. And vesicular olar rash, they will usually come in the tongue, buccal mucosa, posterior pharynx, gum, palates, and lips. This is a very easy entity to recognize, and usually it's like unique somehow. Again, because they come with oral ulcers, which are usually painful, what you need to do is once the patient presents, you're gonna increase the oral intake and rehydrate the patient. Okay, so this is the hand, this is the foot, and this is the mouth syndrome. Okay, so moving on to scarlet fever. So scarlet fever usually it's caused by group A beta-hemolytic streptococcus. It is basically they present with a rash that is known as a sandpaper-like rash texture that blanches on pressure. Usually the rash, the thing that characterizes this rash, that it spreads to the trunk and extremity, but sparing the face. It will not involve the face. And they also come with something called a strawberry tongue or a beefy red tongue. So a lot of us were mixed up between the Kawasaki disease and group A beta-hemolytic streptococcus, who is scarlet fever, because they usually present similarly. They present with a red tongue, they present with a macropapillary rash, but the difference is the sandpaper rash, which can be sometimes found in Kawasaki, but in general it is more with the scarlet fever. Usually, this is not a viral entity. This is caused by group A Streptococcus, which is a bacteria. So you need to treat by antibiotics. You need to give penicillin or amoxicillin, depending upon. Okay, our 12th entity is the acute otitis media. Okay, so in acute otitis media, first off, how they present. They present with irritability. They present with crying, inconsistent crying. They come with anorexia. They usually pull their ears. They present with fever that can lead to febrile seizures. The most common pathogens are the Streptococcus pneumoniae, which is the most common, the non-typable Haemophilus influenza, and Moraxella catarrhalis. Why did we say non-typable Haemophilus influenza? Because it's not caused by a type B Haemophilus influenza type B, which we usually cover by vaccination at the age of 2 months. So that's why this type is not covered by vaccination. How does it happen? So how does the otitis media happen exactly? So first, the patient will present with respiratory symptoms. And then when the patient lies down or when the patient sleeps, the fluid will accumulate in the ear canal. And then this will start to cause irritation for the ear canal, and fluid will accumulate, and you will have bulging of the tympanic membrane, loss of light reflex, and the ear symptoms we mentioned before. So how do you treat? I remember a question coming about how do we treat otitis media. Usually we treat with amoxicillin, very high dose amoxicillin, 90 milligram per kg per day, depending on the patient's age. So if the patient is less than 2 years, we manage for 10 days. And more than 2 years, we manage for 5 days. Okay, our 13th entity is the pharyngitis. So we have two types of pharyngitis. We have bacterial and we have viral. Bacterial is most commonly caused by group A Streptococcus, and viral is caused by viruses. So as you can see the picture over here, we can clearly see the difference between them. But I'm just going to point out several differences that are important to know. In the bacterial, you're going to have exudate on the tonsils. In the viral, it's only an erythematous background. There's no exudate, as you can see. Okay? And the bacterial, in the viral, you're going to have symptoms such as the 3 C's, the conjunctivitis, coryza, and cough, as well as hoarseness. And the bacterial, this is not present. They don't come with cough. They don't come with coryza, conjunctivitis, and these symptoms. Usually, in the bacterial, they come in ages more than 5. In viral, it can come at any age, either older or younger. Usually, bacterial, they present with high-grade fever. Viral, it's not a high grade, it's usually low grade fever. And then in bacterial, you're going to have a unilateral tender cervical lymphadenopathy. So you have swelling of the cervical lymph nodes, and it's very tender, and it's only on one side. For viral, it's going to be bilateral, and it's going to be non-tender. In bacterial, you're going to have sore throat. Viral, it's not really common to have sore throat. So this schedule just shows you the differences between them, but we have talked about the most important ones. Okay, the center criteria. Center criteria is how we know that this pharyngitis is usually or most likely caused by group A Streptococcus. So as we mentioned, the temperature is going to be more than 38. You give it 1 point. Absence of cough, 1 point. Tender cervical lymph nodes, 1 point. Exudate, 1 point, and etc. As you can see, the most common age by which bacterial pharyngitis occurs at is 3 to 14 years. Keep this in mind because we know that if we did not treat Streptococcus, group A beta-hemolytic Streptococcus, we're going to have an entity called rheumatic fever, which is very common in this age, and that's why our question would be, do we have to treat group A Streptococcus? The answer is obviously yes. Why? Because we will have rheumatic fever if not. Not only rheumatic fever, you can have other disorders such as glomerulonephritis, peritonsillar abscess, so it's very crucial to treat group A Streptococcus pharyngitis. Okay, what rheumatic fever is, it is basically, we have something called a modified Jones criteria, which can be divided into major and minor criterias. I think most of you guys already know about Jones criteria, but just a quick recap, we divided the patients into low risk and high risk populations. A low risk, you have arthritis, cardiitis, Sydenham chorea, subcutaneous nodules, and erythema marginatum. There's slight differences between both higher and low risk. And minor criteria, you're going to have polyarthritis, elevated body temperature, acute phase reactants, and prolonged PR. So for you to say this is a rheumatic fever, you need to satisfy 2 major and 1 minor, or 1 major and 2 minor. Plus, usually something that most of the students forget about, you need to have evidence of streptococcal infection. This is very crucial. You cannot say this is rheumatic fever if you don't have a streptococcal infection. So how do we know? What do I mean by evidence of streptococcal infection? We mean we need it either to do a culture, anti-streptolysin or titer antibody, which is an antibody against the streptococcus, or rapid antigen testing. Any one of these is considered as an evidence. So how do we treat these patients? So usually if the patient has rheumatic fever, already has a rheumatic fever, without cardiitis, he does not have any cardiitis, you're going to treat for 5 years or until the patient reaches the age of 21. Okay, but if the patient has rheumatic fever with cardiitis, you're going to treat for 10 years or until the patient reaches the age of 21. Finally, if the patient has rheumatic fever, cardiitis, permanent valvular heart disease, you're going to treat for 10 years or until the patient reaches the age of 40. Or sometimes we treat them indefinitely, yani forever, because they're extremely immunocompromised. Okay, moving on to Impetigo. So we have 2 types of Impetigo or Impetigo. We have the non-bullous and the bullous. I put the non-bullous in bold because it's the most common. So what happens exactly is that you're going to have papules that will turn into small vesicles. Vesicles, again, هي عبارة عن sacs filled of fluid surrounded by erythema. So the vesicles and pustules will rupture, leading to oozing secretion. As you can see here, this will lead to honey-crusted lesions. So if always in the questions they would say honey-crusted lesions, so directly you will choose Impetigo because it's very clear. This is their presentation. Usually they come, they're usually caused by Staphylococcus aureus or group A beta-hemolytic Streptococcus, and it usually occurs between the age of 2 to 5. So what about the treatment? Usually simply, if the lesion is only minor and it's usually localized and mild, you're going to give only topical antibiotics. From us, we weren't required to memorize any of the topical antibiotics, but for your knowledge, you can know it's mupirocin. But for if the infection was severe and it was disseminated and widespread, you would give narrow spectrum systemic antibiotics, such as fluoxetine or so. Okay, finally, our last entity we will be talking about is the UTI. So in the UTI, first of all, you need to understand that we have 2 parts. You have an upper urinary tract infection and you have a lower urinary tract infection. So let's start with the lower. And the lower, how will they present. They will come with hematuria, they will come with increased urinary frequency, they will come with urinary urgency. Urgency means it's an overwhelming need to go to the restroom immediately. يعني they need to go right now. Suprapubic tenderness and dysuria, which is difficulty in urination. This is the lower urinary tract symptoms. As you can see, most of them are related to the urinary system. For the upper urinary tract infection, usually they present with more disseminated symptoms, you can say, or more of a systemic symptoms. They come with symptoms of lower tract infection, which is these symptoms. They present with fever, flank pain, fatigue and malaise, nausea and vomiting. So how would we actually diagnose them? The gold standard in UTI, this is very important because they usually ask about what is the gold standard, what do we do, and etc. So the gold standard is urine culturing. But because it's a bit time consuming, what we can do in the meanwhile is we do urine analysis to detect leukocyte esterase and nitrates. طبعا usually in most of the UTIs, esterase and nitrates are there. So you can say they're semi-specific for UTIs. The most common pathogen is usually E. coli, but it can be caused by other gram-negatives such as Proteus, Klebsiella, Pseudomonas, and etc. You have a long list. How do we treat? Usually, both oral and parenteral treatment. Both oral and parenteral treatment are equally effective. Both of them are the same thing. But obviously, if the patient cannot take oral, for example, a decreased level of consciousness, or he's consistently vomiting, you can give them parenteral antibiotics. Something very important to know is how do you collect the sample? So let's say the patient came, but how do you collect the sample? Usually it depends on the age of the child. So if the child is still not toilet trained, what you can do is either castration or suprapubic aspiration. طبعا the more sterile option is the suprapubic aspiration. If the child is toilet trained, what you can do is take a midstream urine. Midstream urine means the patient will urinate for a bit, and then you're gonna collect the urine in the middle, and then the patient will continue urinating. So you're taking the sample in the middle of the urination. And then usually we don't really use bags to collect urine because of the high risk of contamination and false negatives or false positives. So we only depend on a bag to be we only depend on a bag result if it's negative. So if it's positive, we don't really take it into consideration because we may have a lot of false contamination. So that was it for our talk today. I hope you guys enjoyed. Thank you all for listening. So please don't hesitate to contact me and find me at the following. And for any questions, please don't hesitate to ask. The only thing I haven't covered in this portion is the adenovirus. Adenovirus, I think most of you are familiar with it, but because for the time's sake, I didn't mention it in the lecture, but please go back and read it very quickly. It's very easy. And these are the references I used. This book is very, very important and for me, it was very informative and helpful, which is the USMLE Step 2 CK Q&A. There are a lot of scenarios similar to what we encountered in the exam. So if you have time, just pass upon it, not only for the infectious agent lecture, any lecture. It has a lot of topics. So thank you everyone again, and I hope you have a great day.